Okay, this is a feline cat spay. We have a patient that's draped, instruments all ready. If you notice, with this drape, I am draping where the umbilicus, which is this little white thing that's just peeking out cranially on the drape, is in the cranial aspect and just on the edge of this drape. When I'm gonna make my incision, I'm gonna make my incision halfway between the umbilicus and the cranial edge of the pubis. So I can feel right here in the cranial edge of the pubis, and that's where the pubis and the bony structures drop off into the abdomen. So from here to here, my midpoint's gonna be right about there. And so this is where I'm gonna make my incision. There's three things I'm gonna do before I start cutting. The first thing I'm gonna do is I'm gonna cut my swabs, and I have 5 swabs in our pack. I'm gonna ask anesthesia, are you ready for us to go? I'm gonna head nod. And the third thing I'm gonna do is take a nice long breath in, hold it in, and slowly let it out. And that just relaxes the surgeon a little bit. So we're gonna go right in the midline between my cranial edge, the cranial edge of the pubis from the caudal aspect and the umbilicus. We're gonna make an incision stretching out the skin, and this incision is just gonna be big enough for us to get our spay hook in. I went through the fat a little tiny bit. I'm happy with my incision placement. I'm then going to use my mosquito hemostats, and I'm going to use them with the point down. I'm going to go into that hole and I'm going to expand it. And by expanding it, I'm ripping through the fat to give myself better visualization. And you can see the linea alba poking out. This is a very skinny cat, but if you had a bit of a fatter cat, you can expose the fat a little bit. Now notice I say expose the fat. I don't say remove the fat, because there's no need to remove it and create extra dead space. But if I did need to, I would grab the fat from the inside. And all I'm trying to do is I'm trying to match up the fat incision with my skin incision, like that, cranially. And I'll do the same thing caudally, just to make sure that I have really good exposure. And sometimes I have a little bit of a remnant of fat over the linea alba. I'm just making sure I'm giving myself a nice look into that linea alba. Once I do that, I'm gonna get my forceps. I'm gonna pick up my linea alba. And at this point, I'm just trying to get a grasp of it. And I'm gonna walk it up cranially, just a little bit so I have good exposure and a good grasp. I don't wanna go too far because it's very easy to get a bit ahead of yourself and go further than you need to. And then you're gonna be closing from underneath your skin. But once I'm happy that I have that, I'm gonna use my scalpel and I'm gonna go a little bit away from the forceps. I'm gonna go with the scalpel blade facing up. I'm gonna push into the linea alba. I usually feel 2 pops. The first pop is going to be the linea alba itself, or the rectus sheath where it comes together. And the second one is the perineum. And I'm gonna let go and allow the scalpel to finish my incision. At this point, I'm gonna take my atraumatic tissue forceps, the forceps, the ones that don't have rat tooths on them. I'm gonna close them. I'm gonna put them into the abdomen, lift it up, and I'm gonna extend my incision caudally. And then going to flip so that I have them in my right hand. Put them in, extend a little bit, and extend my incision. My incision was actually fairly well placed, so I don't have to extend too far. What I'm then going to do is grab my spay hook. Now there's 2 ways you can find the uterine horn. You can go closer to me, I'm standing on the right side, and fish it out from the right side, or you can go further away and get it from the left side. There's no right or wrong answer. The right ovary is a little bit more cranially placed. It's the suspensory ligament is attached at the caudal edge of the kidney, not to the kidney, but to the body wall at the level of the kidney. And we know that the right kidney is a bit more cranial, so that's gonna be the one that's gonna be a little bit harder to get out. On the left side, as a right-handed surgeon, if you lift it up, you can kind of get a little bit more of a view of what you're seeing. But with small incisions, that's less useful. And there is this nice little red thing called a spleen that we want to make sure we don't poke or impale. So we want to be a little bit careful about that. And then because of that, I like getting the hard one out of the way. That means the surgery is easier from here onwards. So I like going into the right side. When I go with my spay hook, I'm going to go right in the middle of my incision. I'm going to grab my rectus sheath, or the remnants of the linea alba. If that's proving difficult because there's fat underneath, and you can see I'm grabbing fat and intestines, you can always put the back edge of your spay hook, pull it up, and give it to yourself that way. Once I have that, I'm going to go with my spay hook facing me. I'm going to go right in the middle of the incision, and I'm gonna do 4 things. I'm gonna go all the way down into my gutter. I'm going to flip 180 degrees. That's my second thing. I'm going to sweep, pull up, and then I should have what I'm looking for. Those are the 4 things that we're doing. What a lot of people tend to do is they can tend to go in, flip, and as they're pulling forward and sweeping, they're already pulling up. And what happens is you have your uterine tubes, and it just kind of goes right over it. So you want to make sure that you sweep, hook, and then pull up. So if we try that, we're gonna go ahead and grab what we're looking for. We're gonna go into the gutter, all the way down. We're going to flip 180 degrees. We're going to hook, and we're going to lift out what we have. Now we have some intestines here. I'm gonna push those intestines off. I wanna make sure I don't grab them with my hemostats. And if I have a little bit of fat, I always wanna remove it cranially and see what we're left with. Nothing at this point. Grab again, go into the middle, straight down into the gutter, flip 180 degrees, hook, and gently pull out. You can see I have a little bit of intestine. Hook onto that. Peel that off. And I've got some, and notice I'm holding it with the hook facing towards me. As soon as I go the other way, it helps things fall off. So I want to make sure that it doesn't fall off. And I'm getting rid of things little by little until I have what I'm looking for. Oh, not yet. Grabbing right in the middle, into the gutter, flip, hook, pull up. That's a bit of intestine. I'm going to push that off. And I should have what looks like the ovary right there, and that should be the ovary. I'm going to gently grab that. There's my ovary. There's my uterine horn. And I'm going to look at my anatomy here. So this is the uterine horn. That's going to go into the bifurcation. This ligament is the broad ligament of the structure. I have my round ligament, which is going to be easier to see. You can see it coursing right here, left to right. Sorry, up to bottom. This is your round ligament. Pick that up again. And there we go. And we'll worry about that round ligament later on. I'm going to follow it cranially until I get into the proper ligament. The proper ligament connects the uterine tube to the ovary. And that's great to grab onto and hold onto because it's quite solid. It's more important in our dog space. This is our ovary and the ovarian vessels that we want to make sure that we remove. And then if I push down, I can see I have this suspensory ligament. And the suspensory ligament goes at an angle. The vessels go up and down. So if I pull back, that'll open it really, really nicely. And if I pull forward, that closes that gap. Now you could go in between those vessels and in the suspensory ligament and break off the suspensory ligament. But I find that in cats, we tend not to need to because we usually have really, really good exposure. So what I'm gonna do is make a hole with my instrument close to these vessels in my broad ligament. I'm gonna make that hole a little bit bigger, going up and down. And I do things a little bit differently. I like using back house towel clamps or Alice tissue forceps. In here we have back house towel clamps. So I put them around through the hole in the broad ligament and around the suspensory ligament, across the suspensory ligament. So it's essentially going around the whole structure. What that allows me to do is hold onto the ovary with one hand and with my other fingers push down on the body wall. And you see that it gives me really, really good exposure. Once I have that, what I'm gonna do is put on my clamps. Now the first clamp that I like putting on is nice and low, close to those back house towel clamps, away from the ovary. And the second clamp that I put on is gonna be right next to the ovary. So I know we're taught to use a 3-clamp technique. That's always going to vary depending on how many clamps you use, how many ligatures you put on. If you put on 1 ligature, it's gonna be a 3-clamp technique. If you put on 2 ligatures, it's gonna be a 4-clamp technique. I put on the clamps as I need to, when I need to, because otherwise I have hardware in the way that isn't necessary. Now the suture I'm going to be using today is 3-knot polydioxanone. That's PDS, PDO, PDM, depending on which company makes it. That's a suture that's going to give me the best, longest holding for my linea alba once I close up. And I'm going to use the same suture for the entire surgery. What I then do is I need to put a ligature over the crush mark of that bottom clamp. So I'm going to go with my needle holders through the hole that I made in my broad ligament. I'm going to grab my suture. I'm going to pull that suture forward. And the question is, do I need a circumferential? I'm going to put a circumferential knot on, but do I need a square knot, a modified Miller's, or a surgeon's, more of a binding knot? In this case, because it's a very small stump, or it's going to be a very small stump, it just has a suspensory ligament, there isn't a lot of fat like there would have been a big spay. I'm quite happy just putting in a square knot. I'm going to go into my V, round. I'm going to go ahead and grab my suture. I'm replacing my square knot. And PDO has excellent memory, so it does like to get in the way. I'm going to push that back down. I'm going to remove that bottom clamp. I'm going to push that circumferential ligature into that crush mark, and then I'm going to press and tie it together if I can get my instruments unhooked. Nice and tight. Okay. And now on top of that, I'm going to put at least another 4 or 5 throws. Now with these throws, you want to be very nice and relaxed so that one, you're not jostling the suture underneath. And the second thing is that you're not actually getting slip knots where you should be getting square knots. 2. 3. 4. And 5. Once I'm happy with that, I'm going to use my scissors, cut off the suture. And now I'm going to place my subsequent clamp. And I'm going to cut in between my clamps. So what I like to do is I have my ligature all the way at the bottom. Notice I've put the first clamp and the second clamp really far away. There's 2 reasons I do that. The first reason is when I put this ligature on and tied my first ligature, I didn't have to flash a clamp. Now, in terms of flashing clamps, when you have something attached by a clamp, you see how it's spreading out? If you were to tie this structure with a suture, that clamp would be fighting your tie, and you have to flash it and open it momentarily to close the ligature in order to not have that problem. Because we're so far away, we're not dealing with this problem because that clamp isn't affecting the tissue all the way down here. The second reason is I'm actually able to put my third clamp in between these other 2 clamps. And what that allows me to do is to grab the clamp, let go. This allows me to put my clamp on the suspensory ligament. And notice I'm putting it on the suspensory ligament only, and I'm not actually putting it on the blood vessels. So when I cut, I'm going to cut in between these 2 clamps, this blood vessel is not going to be occluded or constricted by my bottom clamp. The reason that's important is I'll be able to check my bleeding and saves me a step of having to grab it with my forceps. Now when I'm cutting, I'm always cutting from underneath out. We don't want to cut down because if you don't have a lot of room, you can cut into vital organs. Perfect. So I'll remove that to the bottom, and I know that this is holding my suspensory ligament. There is a little bit of blood that was trapped between the ligature and the outlet of where I've actually cut my blood vessel. So that will be a little bit of bleeding, but as you can see, I'm quite happy with that. And at this point, I can go ahead and remove my back house clamp, let that go into the abdomen, unclamp, and we're done with the first side. Now, next thing we need to do is go into the bifurcation, get the bifurcation and extend and find our other ovary. What you'll notice is it'll be a bit difficult sometimes to get the bifurcation because these tissues are actually holding it in place. So what we do is we grab the uterine horn, we pull it cranially, and what that's going to do is it's going to very nicely expand our broad ligament. And you can see our round ligament, which is this nice structure on the other side, that's gonna be attached and it's gonna be holding it in quite a bit. So I'm gonna reflect everything, find my vessels, protect my vessels with my left hand, make a small hole. You don't wanna make a big hole because that big hole is going to start ripping into these vessels and cause bleeding. So I'm gonna make a very small hole. I'm gonna let go of my uterine tube, grab my round ligament and my broad ligament with 4 fingers, and I'm gonna break it. The round ligament is a bit difficult to break, so if you're having a bit of trouble, you know you're in the right place. And what that does is gives me much better exposure, and you can see the uterine bifurcation comes out very, very nicely. Next thing I'm gonna do is grab our uterine bifurcation, follow it up cranially, all the way up until we have our other ovary. And you can see our other ovary connected to the proper ligament. I know I can put quite a bit of tension, or more tension than I would be able to on the tissues on the proper ligament. I'm going to protect that vessel. I'm grab my instruments. I'm going to make a small hole in the broad ligament. Once again, I'm going to use my Beckhouse towel clamps to give myself better exposure. I'm going to push down. I'm going to put my first clamp nice and low. And I'm going to use my second clamp and go right underneath the ovary, just to give myself that room once again. Now, talking about suture selection, while I'm doing this, I'm gonna go in between my clamps and do my circumferential knot. Polydioxanone, or PDS, lasts for about 4 to 6 weeks. Our other option would be monocryl. I'm going to use this one suture to close everything up, and that's gonna include the linea alba. Remember that the linea alba, or the rectus sheath of the rectus abdominis muscle, takes about quite a few weeks to actually heal. We get about 20% of its original strength after we cut it, after about 3 weeks. So we don't want to use something like monocryl that's going to dissolve in 10 to 14 days when we're not even at 20% of original strength. And because I'm using polydioxanone for the linea alba, I'm going to use it for all the ligatures as well. I'm going to go ahead, cut my square knot. I'm going to remove my bottom clamp. I'm going to push that knot down into the bottom. And I'm going to tie it nice and tight. If you're feeling that the stuff's falling into the abdomen, you can always pull back on this clamp and extend it out. You can see we've got really nice exposure. Once again, I'm going into my V, around, grabbing ligature. I'm nice and relaxed. And because I'm nice and relaxed, I'm not loosening that bottom knot. I'm not causing slip knots. If you do, by chance, pull up on one end, you see that'll be a slip knot. All you have to do is just relax down, and that'll give you a nice square knot. And pulling it in opposite directions just to make sure that I'm happy with that. Once I get that, I'm gathering my suture, cutting it off. And at this point, I'm evaluating the size of my vessels, the security of a knot. Am I happy with what I did? And am I happy with my outcome? If I'm not, if I feel like I had a hard time getting it on, I don't feel like it's secure, or I feel like there are big vessels where I want to put on an extra knot, at this point, I would put on an extra knot. However, in cats, that's usually not a big issue. In dogs, obviously, I would put in 2 probably circumferential and transfixing, or 2 circumferential binding knots. At this point, same thing. I put my ligature quite far away from my clamp. I'm going to grab my suspensory ligament. The suspensory ligament is always lateral to the cat. So if you've pulled it out correctly, you'll see we're on the left side, it's lateral. On the right side, it was lateral, so closer to me. Once we're happy with that, we're then going to get our scalpel, and I'm going to cut through. I'm going to cut through from this side, so I'm not cutting into organs. Replacing that, there's going to be a little bit of blood that comes out. I'm going to remove my Beckhouse clamp that was pushing down my body wall, and I'm quite happy with that. Dab just to make sure there's no bleeding. Once there's no bleeding, put it back into the abdomen, unclamp, and let it go. And we're done with the hardest part, and everything is downhill from here. Next thing I'm going to do is we're going to extend and find our bifurcation. You'll notice there's a lot more, going a bit off camera here, but you can see the ovaries are extending a lot more on the right side, which is the first one that I did. And the reason being is, once again, that round ligament. So what we're going to do is grab the uterus, pull it cranially, you see that beautiful round ligament just coming out on here, coming out. I'm going to go quite a bit lower, hold onto the vessels, break through the hole, not rip too far so I'm not ripping into these uterine vessels. Grab with 4 fingers and just gently rip it. Now, if it is a bit too difficult to rip, you most absolutely can use scissors just to gently cut that. Once we have that, we have our bifurcation just coming out. Now, at this point, I'm not going to try to get that bifurcation out if I'm having issues, because it's very easy for it to go right back in. I'll show you a bit of a trick of what I use when I try to get the bifurcation and tie. So at this point, this is a really thick piece of tissue. I don't think a square knot is going to hold it really well, so I need a binding knot. Now, a binding knot is a knot that holds on and securely tightens and doesn't loosen up when there's a lot of pressure. So a binding knot would be a double throw surgeon's knot or a modified Miller's. The modified Miller's is a bit more of a secure knot because there's a little bit less friction with just as much holding power. So that's what I'm going to like to put onto here. So I'm not going to worry that I'm below my bifurcation. I can slide my knot down later on. But what I'm going to do is get my needle holders under both structures. I'm going to pull forward once. And I'm going to go around and pull it through again. And you'll notice that I have a small loop, a short end, and a long end. So normally if this loop wasn't here, if we just ignore that loop, and if this was a square knot, we would go into our V, around, grab, pull through and relax. But since we want to make this into a Miller's knot, what we're going to do is we're going to pull our needle holders into the loop and then do our square knot, just as if that loop wasn't there. And that's going to be our modified Miller's knot. Okay. What I'm doing now is I have my modified Miller's pre-placed. I'm going to let go and place down my needle holders. I'm going to use my pinky, and my pinky is going to go underneath this tissue. And I'm holding that tissue onto my palm, and I'm pulling it out. You can see it goes nice and low below the bifurcation. And once I do that, I'm then grabbing the needle holders with my index finger and thumb and using the other hand to tighten. And once I do that, and I'm happy with that, then I can go ahead and let go. And I've got a really nice paid modified Miller's, which is nice and low below the bifurcation. I'm going to tighten that again. And then 4 or 5 on top of that, once again into the V, nice and relaxed, pushing everything down. 1, 2, 3, 4, in addition to my first one. Pull those both up. Get my scissors, cut that nice and low. Once again, I'm really happy with my modified Miller's. It's a very nice secure knot. I'm happy with just having 1, not needing 2, so I'm not going to put any more on top of that. Now, the other thing that we didn't talk about is clamps. I didn't actually put clamps onto the uterus before I put my ligature in. I didn't have any crush marks. And the reason is this is a cat. This cat looks like it might be in heat, and they can be very friable, so we don't want to put clamps on before we actually make sure we have a good ligature. If this was a dog, of course, I'd be putting clamps on. What I'm now going to do is I'm going to put my 2 clamps on. I have my bifurcation. My first clamp goes, well, it doesn't matter which way you go, I'm going to go from the bottom up. My first clamp is only going to go halfway. So you've got a vessel, a uterine vessel on the left side. You've got a uterine vessel on the right side. I'm going to go halfway, and I'm only clamping 1 uterine vessel down. With my other clamp, I'm going to go all the way across. And I'm going to cut in between. And you'll notice, once again, once I cut in between, this vessel is not protected. And so if this ligature isn't holding, that will bleed quite a bit. This vessel is protected, and therefore it won't bleed. But by the laws of physics, we know that if this one isn't bleeding, then this one isn't going to bleed either. I'm going to go upside down, so I'm cutting away from my animal. Remember, with scalpels, you have to do a sawing motion. A lot of people I will see will just press through. You have to actually go back and forth. I'm going to remove my uterus. I can see there's a little tiny bit of speck of blood that was trapped in between the ligature and the vessel. Pressing it in. I'm also relaxing it down a little bit, because sometimes just by pulling up on it, you'll actually get rid of the pressure and stop the bleeding. And I'm quite happy that this isn't bleeding. I'm going to go into the abdomen. I'm not going to let it go here because it's going to get trapped over the skin. I'm going to go in the abdomen, clamp, and let go. I'm going to dab a little bit into the abdomen just to make sure I don't have any excessive bleeding. And now I'm going to have a decision time. Do I actually go in there and check and make sure with my swabs that I don't have any bleeding, or do I just close it up as is and not disrupt the tissue? And I'm going to like to do the latter. You could, if you wanted to, grab your swab, make a nice little thin point, and go into each gutter and check the gutters. If this was a really big spay with huge vessels, if there was excessive bleeding, if I was worried about the security of my ligatures, I might go ahead and do that. I'm not going to do it this time because it is not a benign procedure. I'm going to either poke the spleen, probably make a hole in it, or possibly rub up against the organs and cause a bit of damage. I'm not going to do that unless I need to. So things to do before we close up. We're going to make sure we count our swabs, and we have 1, 2, 3, 4, 5. Now I know I'm not going to leave a swab in such a tiny hole, but it is good practice. And now I'm going to go ahead and close up. When we close, we're always suturing towards the forceps. I'm right-handed, suturing on the right hand of the cat. So I'm going to start caudally and suture up cranially. If you were left-handed or on the other side, you always make sure you suture towards forceps. What we're actually trying to suture here is what used to be the linea alba. Now the linea alba is composed of the rectus sheath, and this is a really, really good example. You can see the muscle here. This is your external rectus sheath, and down in the inside, where the fat is attached to it, we have our internal rectus sheath. All we want to do is make sure that we get the external rectus sheath attached. We don't need to get any muscle because that's going to cause muscle necrosis and pain. So I'm going to go about 2 millimeters away. I'm going to grab just that rectus sheath. I'm going to go underneath it fully, but I'm going to go through the muscle. I don't need to go full thickness into the muscle because all that's going to do is that's going to cause suture to rub up against the organs, and that's going to mean that I'm going to have more suture than I need to suturing this close. I'll pull that up, maybe around, grab, nice and relaxed. This is appositional. The other sutures that we've been doing up until here was occlusal, so we were really tightening really hard to stop blood flow. With this one, we just want to oppose these tissues together anymore, and we might be actually cutting through the rectus sheath, and if we did get any muscle, we'd be causing muscle necrosis. So just gentle. And notice I did a square knot. Pulling, it's perfectly fine. It doesn't open up. Now, if this was a big dog spay or a bitch spay, and I was getting this tissue pulled apart, then I might put a surgeon's knot on top of that. Once again, we'll put an extra 5 on top of that. 1, 2, 3, 4, 5 for a total of 6 throws because this is the start of a continuous suture. Notice I'm nice and relaxed. I'm going to pull up my short end. I'm going to go ahead and cut my short end. And I'm going to continue up cranially. Notice I'm also not touching my needle. I'm holding it with just the forceps. I'm pulling on the long end very gently just to lift up the tissue that I'm interested in, letting it go. And I'm going to go just onto the rectus sheath on one side, rectus sheath on the other side. Before I unclamp my needle holders, I'm going to hold this needle with my forceps, pull it through, and then reclamp it right away. So I don't have to worry about reloading it every single time. Through my rectus sheath, I'm going to pull this fat out of the way. Once again, through my rectus sheath, lifting this fat off. Making sure I have a really good bite of this rectus sheath on this side. Grab, reload, pull through with both fingers. Grab the rectus sheath, gently through that rectus sheath. And I'm suturing back and forth about 2 to 3 millimeters away until I'm happy that I'm at the cranial edge and I can barely, actually I don't think I can actually see any openings. I'm just going to grab both of these and make sure put them all the way to the end. Now at this point I'm going to leave a little loop. This is going to be the short end of my suture. I'm going to go into maybe around, grab the loop, pull it down and through. I'm going to open it up, open up the needle holders as I pull through. And just that positional, that's going to make sure that I equilibrate both sides of the suture. Grab, pull through, open, around, grab. Now what a lot of people do is they will pull through, and they'll pull through really hard on this, just because it's habit. Notice that's a slip knot. So I need to be really nice and relaxed to make sure that goes back into a square knot. Around, grab. And I've lost count. I'm going to put a few more. I want to do one more than I started with. I started with 6, so I'm going to put at least 7 on here. Once I'm happy with that, I'm then going to cut off my loop. In decision time here, I have few options. One, I can fully close the sub-Q and then do an intradermal on top of this. But because my incision's so small, I'm quite happy that leaving the sub-Q open won't cause that much dead space to be left behind. So I'm actually gonna leave about an inch or so, about 2.5 centimeters here of suture, just so that once I do complete my intradermal, I can then tie it off to that suture, not have to bury the entire suture. Once again, same thing applies to the intradermals. We're gonna start caudally and go cranially. Now this is, once again, suturing towards your forceps. What I do, now this is just my little trick, when you're suturing intradermals, you go deep, superficial, deep, because you want to bury the suture, and you start at the cranial edge. I like starting a little bit closer, about 1/3 to half of the way through. And what I do is make sure to grab a large bit of fat and go nice and deep and come out through that sub-Q. I don't want to come out close to the dermis because I'm going to go backwards, but I'm going right in the middle of that incision. And then I go on to the other side. This cat doesn't have a lot of fat, so it doesn't have a lot of sub-Q. The sub-Q is very thinly hidden. I'm going to grab the fat. I'm going to invert the skin actually and just grab it this way. Okay. And so I have 2 deep ends. They're both pointing inwards deep into the animal. And I'm going to once again, appositional, close this up. 1, 2, 3, 4, 5, nice and relaxed, 6. Going to go ahead and cut off the short end. Now you've noticed that because I've put my initial anchoring tie a little bit further cranially than caudally, what it also does is it closes a bit my sub-Q, so it gives me a little bit more dead space. I'm then going to go ahead and grab my needle, pull it backwards. I'm going to pull on the actual suture. I'm going to go underneath, and I want to make sure I go all the way to the end and come out right at the bifurcation. That skin is just cut out from the dermis. And I'm going to pull that through. And what that does is it sucks on my knot, which is nicely closing up the sub-Q, and then I'm right where I want to be starting with my intradermals. Now with intradermals, there's 2 things that you need to remember. One is when you're suturing, no matter how you hold everything, the needle always has to be completely parallel to the dermis. And the other thing is, you have this really cool contraption called wrist. So it's absolutely fine to use that wrist to follow the curve. I like starting out away from myself, but it doesn't matter which way you start. I gently grab the skin, evert it out, show myself the dermis, go into the dermis, follow through, and come out. And it's a bit difficult to get through. If you're going through like butter, then you're probably in the sub-Q. You want to make sure you're in that dermis. I'm going to grab close to me, evert it out. I'm going to go, that was way too easy. Right from the edge into the dermis, through and out. And if you've done that correctly, that should start closing that area really nicely. Once again, out, parallel to my dermis, going through. I want to go through the skin. If you do that, you just back up. make sure you come out right at the dermis. Pull through. That's closing nicely on my side. Evert into the dermis. Travel a little bit. Come out through the dermis. Pull through. And you can see that that's very nicely closing. Evert out. Come in through the dermis. This cat especially does not have much of a dermis, especially thin cats. And come out. Pull through. If this little tag is in the way, you're more than welcome to put a hemostat on that, and that hemostat will just weigh it to get it out of the way. Pull that through. And at this point, I'm evaluating how far away I am. I think I'm going to put one more that's going to go all the way to the end, and then I'm going to do my superficial deep. Remember, when you're doing an intradermal, you're completely out superficially, and this is a deep tag. That's from the deep end of the animal, so you want to make sure that you match them up when you're tying. So you're going to go on my side, gently evert it, go into the dermis. I'm going to try to go as far as I possibly can on this. Make sure to come out in the actual dermis. There you go. Pull that through. And then what I'm going to do is I'm going to take the other side and I'm going to go deep to superficial. And I happen to be going from the other side. You can go on your side, doesn't make a difference. It just depends on how many ligatures you have. Now what I like doing is grabbing this, everting it completely out and going into the dermis and coming out nice and deep. And what that allows me to do is invert everything really nicely into the animal, and I'm left with a long end and my short end that I can then tie off. Once again, V, round, grab, gently. What I'm looking for this here is I'm looking for that ligature, for that knot just to disappear underneath the skin, just like that. I'm not tying it any further. If you tie it very strongly, you will accordion the whole entire suture line. So the first one and the second one kind of locks into place. And the third one you can be a little bit stronger on. Nice and relaxed when I'm tying. Wonderful. Once I'm happy with that, I'm cutting off the short end because we need to bury that suture. So while both these suture tags are coming out from the deep end of the animal because we've stuck them out from the skin, they're everting out. What I'm going to do is grab my needle. I grab the suture, and you want to go right next to that hole. So the same hole that this suture is coming out, that's the same hole that I want to go back in behind my suture, next to my suture. There we go. And I'm going to come out far away from the animal, from the suture line. Pull that through, and that should invert my suture. I'm going to hold my suture, put 2 fingers on the actual skin, push it down while I'm pulling through. I felt a bit of a pop. That pop was the suture coming around. I'm going to cut nice and close to the skin and have a really good closure without any suture coming up. And that's my way of doing a feline spay.